Thanks for joining me at Student Nurses Success. The video today is going to cover thought disorders. I'd like to begin with our blank map. When we're talking about thought disorders, we're really talking about marked dysfunction in multiple areas of life. So these are significant mental health disorders and disorders that really significantly affect multiple areas of individuals' lives. Let's begin with we have three that are considered psychotic illnesses. And the first is schizophrenia. When we're talking about psychotic illnesses, we're really talking about illnesses with disordered thoughts or behaviors, and that's schizophrenia is. Schizophrenia, we're not certain really what is going on with schizophrenia. We do know that genetics can play a role in schizophrenia, so that we do see some increased incidence in families, but we're not really certain as far as the pathophysiology. The following things we do consider may be related to the development of schizophrenia. In some individuals, they may have excessive dopamine, which causes what we call positive symptoms. Our positive symptoms are actually down here. Positive symptoms include hallucinations, which is a perception that is not present, or something that you think is there that is not. Psychoses, which is really just a loss of touch with reality. So you're really just not thinking within the realms of reality. And delusions. Delusions are firmly held beliefs that are not true. So maybe thinking that someone's out to get you when it's not really true. We also know that, or suspect that dopamine deficiency may also play a role in schizophrenia. Some individuals with schizophrenia may have what we call negative symptoms. Negative symptoms include depression, low mood, um, very low types of activity levels. We also think that GABA may play a role in the development of schizophrenia and serotonin as well. So those are neurotransmitters that we suspect are related to schizophrenia. When we're talking about other manifestations beyond the positive symptoms and the negative symptoms, people with schizophrenia often display cognitive impairments or symptoms as well. So they may have changes in executive functioning, which include difficulty with memory, difficulty making decisions, and even difficulty with attention types of issues. Schizophrenia is very challenging to treat, and a lot of times it's because of the positive symptoms, the delusions, and hallucinations. But if on medications, individuals do very well. However, if they do not take their medications, then often we lose touch with them, and they are a significant portion of the homeless population. Let's move on to major depressive disorder. That is also considered a psychotic disorder. And really, when we're talking about psychotic disorders, it's really just a loss of touch with reality, thinking things that are just not necessarily true. With depression, we have these persistent feelings of sadness, hopelessness, and even loss of interest. As far as the causes, we think there's some link with genetics there. Medical conditions can also cause depression, or imbalances in serotonin and norepinephrine have also been suspected in causing depression. Manifestations are a range, and you may not have them all, but there's usually a certain number of criteria that meet the definition of depression. So individuals may have any one or more of these: insomnia, fatigue, appetite changes, which can be either increase or a decrease in appetite, low mood, irritability, inability to concentrate or focus, feelings of guilt or worthlessness that are certainly not true, but they think and really truly feel that they are, decreased pleasure, and even thoughts of self harm or suicide. Now, with depression, symptoms must be present for a period of time, and they really are affecting their ability to function and carry out their activities of daily living. Bipolar is the last psychotic illness I'm going to cover in that category. With bipolar, we think there's a possible imbalance in dopamine and serotonin and norepinephrine. Manifestations of bipolar really cycle between two. One is mania, where they have excessive energy, inflated self-esteem. They may engage in very little sleep and have a very elevated mood. And then the other is depression, and certainly the feelings that we just talked about with depression, the feelings of sadness, hopelessness, or loss of interest. People with bipolar will actually cycle between these two. We know that their depressive phases tend to be longer than their manic phases, and we tend to try to treat this with mood stabilizers to kind of balance that off so they're not cycling in between the two extremes. Now let's move on to our non-psychotic illnesses. And our first will be personality disorders. Personality disorders are really defined as behaviors that are inappropriate in a cultural context. Two in particular, antisocial and borderline. Antisocial personality is really where the morals are just not consistent with society. We see antisocial personality uh, a lot in the prison system because their morals just aren't consistent with those of society, so they often are incarcerated. Borderline personality are unstable, dependent relationships. Sometimes they can be in abusive relationships where they just have this need to kind of constantly know what's going on or be with someone. So, someone who's in a relationship with someone who's borderline can experience maybe domestic violence or abuse, and those who have borderline may be the ones who are controlling and doing the abuse. They also may have self-destructive behaviors such as cutting. Move on to OCD or obsessive compulsive disorders, another one of our non-psychotic disorders. Obsessions are these constant thoughts. Compulsions are the ritualistic behaviors that people may undertake in order to deal with those thoughts. Going back and occasionally checking to make sure that you turn the coffee pot off or that you close the garage door is not a big deal. But when you're just all day long worried about it, thinking about it constantly, and having to keep going back to check these things, and it's interfering with your ability to participate in your activities of daily living and in areas of your life, then it becomes an issue. Anxiety disorders, we have three of those that we're going to talk about. The first is panic attacks. Panic attacks are acute, unexplained anxiety or fearfulness. They are a sudden onset. So they just kind of come on suddenly. We'll see an increase in heart rate, increase in respiratory rate, even tremors. We think it's possibly an excess in norepinephrine that is kind of stimulating that. Generalized anxiety disorder, often abbreviated GAD, is chronic exaggerated worry. Just this kind of constant low level worriedness. Patients may have restlessness, fatigue, difficulty focusing, just chronic worry. We think there could be an alteration in serotonin and norepinephrine levels implicated in this disorder as well. Our last anxiety disorder is post-traumatic stress disorder, PTSD. PTSD is intrusive thoughts, maybe intrusive dreams, sleep disturbances, and they are usually linked with some type of event. And that event, linked with some type of event, let's get that in there. And that event is more than a month away. So what I mean is, let's say you were held up, carjacked, or held up, or something very traumatizing that happened. It would be pretty within normal limits to be very upset, have difficulty sleeping. within, the first few weeks after that. But with PTSD, these are things that go on for months, years later. And the PTSD is very difficult to manage. A lot of people suffer in a lot of silence with PTSD, and sometimes do commit suicide related to that. Let's move down to neurodevelopmental disorders. These are not psychotic or non-psychotic disorders. These are developmental disorders. The two I'd like to talk about are ADHD and ASD, or autism. ADHD, or as we usually know, attention deficit hyperactivity disorder, is usually uh, abbreviated ADHD, is really characterized by distractibility, impulsiveness, difficulty with organization, difficulty with focus. Some individuals may have excessive movements or hyperactivities, but it doesn't mean that all do. So you can have ADHD without that hyperactivity, just have the impulsiveness and distractibility. So individuals with ADHD are highly distractible, have trouble completing tasks. The couple definitions, or the couple criteria I want to make you aware of, is one, the onset is before age 12. So this distractibility happened before the individual was 12 years of age. However, it may not be diagnosed until they're 20 or 30, but it can be traced back to them having these issues in childhood. The other is that with ADHD, these symptoms must be present in more than one setting. So it can't just be you're distracted at school or you're distracted at home. It has to be in more than one setting. In both settings, it needs to be present. Um, ASD, or autism spectrum disorder, we know is increasing in prevalence. We see a lot more cases of it today. It's really consists of social difficulties or difficulty with social cues, repetitive types of behaviors, restricted interests, and a degree of inflexibility. Individuals with ASD, there is no cure. However, we do know that early educational interventions are key to really helping individuals move through childhood into adulthood with some positive outcomes. Our last thing I want to talk about in our thought disorders is neurocognitive dysfunction, which is really just a decline in mental function that interferes with activities of daily living. We're really talking about Alzheimer's is really kind of our exemplar here. Alzheimer's disease is a syndrome. We know that there is atrophy and deterioration of the brain. As far as the causes, it's related to genetics, possibly environmental triggers, someone who maybe has had past history of traumatic brain injuries or high blood pressure. We know vascular changes in the brain can cause the development of Alzheimer's dementia, inflammation, and even our oxidative stress. So sometimes we kind of refer to this as dementia. The patho behind it is really the brain starts to atrophy and shrink. We know that there's a development of these amyloid plaques and tangles within the brain, and those lead to scar tissue that accumulates in the brain. It starts in areas of memory and cognition first, in some of those executive functions, and then later spreads throughout the brain and continues to deteriorate function for the individual. We know that acetylcholine is significantly reduced in those with Alzheimer's. As far as manifestations, usually the first few ones that we notice are short-term memory loss. Over time, maybe some personality changes, difficulty with abstract thinking, agitation. We really see as things progress, eventually leads to loss of ADLs, weight loss, inability to remain continent, and eventually the ability to swallow and walk and move will occur. The other thing I want to just bring your attention to is delirium. Delirium really is a global dysfunction. It is not dementia. It is resolvable and reversible. It is short term. So it is not a long-term thing. With delirium, we see patients may have confusion, hallucinations, and it's often from a lack of sleep or a change in routine. So anybody you put them in the hospital and kind of change out their routine, and they may get kind of confused. Maybe where they're not sleeping well, and delirium can set in. So, delirium is not the same as dementia. There you go. Remember to check the comments for the link to the maps, and I hope you have a wonderful day.